Hello, I'm Professor Michael Jordan, and I'm a specialist in HLH at Cincinnati Children's Hospital. I'm joined today by my colleague, Dr. Kate Kernan, a pediatric intensivist at UPMC's Children's Hospital of Pittsburgh in Pittsburgh, Pennsylvania. So in this module, we'll discuss what is the best practice for diagnosing HLH in the critical care setting. So welcome, Dr. Kernan, and let's get started with the case. So you have a patient present to you that's a male, 12 months of age, with persisting fevers, has very fast, shallow breathing, has evident splenomegaly, a generalized rash, and is otherwise previously well. What would you, in your context, what would you sort of start with as for your most likely differential diagnosis?
Sure. Whenever we're seeing a young child, really of any age, with the chief complaint of fever, the most likely etiology in the pediatric intensive care unit is going to be infection. Whether or not that is bacterial or viral typically becomes the first sort of consideration. Certainly more unusual infections, things like fungal or protozoal, can come up, although that's more typically in children that are not previously healthy. And so I think those are sort of the most common when we start to think about understanding when we should have suspicion for more atypical diagnoses, particularly things like HLH. And we have to sort of keep your mind open for a wide net because, obviously they're the most common, but they're not the only things that present with fever and rapid breathing. Presumably, other signs of shock is sort of what we're talking about here. And so, I think other less common etiologies, things to consider, particularly like the longer the fevers persist and those sorts of things become, things like malignancy, other rheumatologic conditions. Certainly in our very young children, we think about kind of inherited conditions. And that's a time when we perhaps start entertaining, diagnoses like primary immunodeficiencies or other HLH type conditions.
Mm-hmm. Right. So the patient is described as pretty generic, right? Probably 90 something percent of the time is going to be infection, right? So what sort of features would make you, like if you could sort of list them out, what sort of features might make you think, hey, wait a minute, this is something out of the ordinary, perhaps?
Yeah. I was sort of thinking about this when we were getting ready for this. Is it sort of when does something trip over that you start to become suspicious for this? And I think there's sort of, what I came up with when I was thinking about this is three sort of scenarios. One is, lack of improvement, which I think is probably the most common over the typical trajectory. For most intensivists, if you're doing supportive care for a viral infection or definitive therapy with antibiotics for a bacterial infection, you're typically expecting to see improvement, in that 48-hour mark, I would say, somewhere in that 24 to 72 hours. But so in those cases of children where, they're not showing that predicted trajectory of improvement, that's a time when I try to be suspicious. The second scenario is in, settings of profound systemic inflammation. So, I think time is critical with this diagnosis, like many. And so there is sort of that next gear of speed when it comes to, the really extremely critically ill patient, where I think it's essential to be suspicious, from when they kind of show up and you meet them. And that tends to be in a patient with really significant inflammation and signs of multiple organ dysfunction. And then the other one, which I think is trickier to just be mindful of, and something I think we'll touch on during these discussions, is in the setting of unexplained CNS disease. And that one is tricky, but it's important to be aware of sort of isolated presentations of HLH type disease with really limited to CNS manifestations. And so that's something that I think it's important to bring up in sort of these teaching scenarios is some place where, as the intensivist, you have to continue with that level of suspicion.
Mm-hmm. Yeah. And just to take it back to the more generic patient, because I do think it's a great touch on that sort of the more isolated CNS presentations, but back into the generic setting is, what about cytopenias, right? So in the ICU, you see lots of cytopenias with DIC, and what point, if you're seeing a febrile patient who's maybe has sepsis, maybe has DIC, but then again, maybe has something else, right? At what point does cytopenias make you concerned? And at what point do you start thinking about calling in the consultants, for instance? Which ones would you call, for instance?
Yeah. I mean, I think in terms of the cytopenias themselves, it's really not uncommon for day one of presentation for an infectious, to see. Certainly thrombocytopenia is probably the one we encounter most commonly, some mild degree of anemia in the setting of a bad sepsis patient. That is very typical. When you're starting to see neutropenias, white cell count abnormalities, and again, particularly if they're persistent, beyond that first 24-hour period, we do see just sort of variation in CBC values that come in the setting of that acute stressor, that may be present on the admission CBC, but they're not there the following morning or in the afternoon, that are sort of more reactive. Those are scenarios where I'm less concerned. If the abnormalities are persistent, I would say over 48 hours, my level of suspicion goes up. Who you call, I think, is an excellent question, and in some cases a little variable from shop to shop. But in a generic sense, the younger the patient, the more likely I am to call my colleagues from hematology and oncology. By kind of history, other signs and symptoms of rheumatologic disease, skin rashes, joint abnormalities, family histories, those sorts of things may be more likely to call rheumatology. By the time I'm calling those folks, I'm always calling infectious diseases, just because they're, as we sort of stated, most of these cases, infection, plays a role, either in and of itself can cause the entire presentation, or is in some way related to the presentations for things like HLH and MAS. And so having their expertise is helpful. And certainly at anybody, 48 hours in, if we're not getting better on our routine standard therapies, if we think it's infectious, we would be calling them as well.
Mm-hmm. And by the way, since you're in Pittsburgh, I have to ask, do you guys routinely check a ferritin when somebody rolls in the door with the sepsis?
I wouldn't say not everybody, but anybody that's acting funny, yes, absolutely. It's a pretty common. That's sort of what I said. I separated into three buckets. Is the non-improving kid will get their ferritin checked on 48 to 72 hours. The really, really sick child, in that really can be a very non-specific generic term for very sick, but to me that means really profound multiple system involvement. They almost always get ferritins checked on admission to the ICU, because our level of suspicion for this and sort of related type conditions is high. And it's really quite helpful. But so that's what I mean when I say, when you think about, if it's bad enough, you should be thinking about this, in the setting of an inflamed patient with severe organ dysfunction. And so those kids, we check them pretty quickly.
Yeah, it has been suggested by people outside of Pittsburgh too, I know, that
I think it's coming. I mean, it's definitely something we spend a lot of time working on here, but we're not the only institution in the country that practices in this way, and certainly it makes things complicated, because you learn that HLH isn't the only thing that makes your ferritin go up, but similar to CRP and other inflammatory markers, it does mean something significant is happening, and that's useful knowledge for an intensivist.
And by the way, just to swing back to the CNS presentation, so these would be patients that presumably are not in multi-organ failure, that you still could assess their neurostatus perhaps. Maybe they're in status epilepticus, or they have some other sort of thing that lands them in the ICU, but they have a clear neurologic pattern. So what sort of features would make you think more about HLH perhaps in a child like that?
Yeah, I mean, it is hard. This is a hard group to have suspicion for, to pick up on, and I think it's important to talk about in that respect. Yeah, we are almost always thinking about this in a child that has an acute presentation of a CNS disease, and so that's things like altered mental status, very commonly seizures, focal neurologic deficits, although that's not as typical for the cases that I've seen. And so in sort of the evaluation for those, very routine procedures would be things like a lumbar puncture and head imaging. When you're seeing signs of significant organ-limited inflammation, and most typically we're talking about things like pleocytosis, elevated protein on LP, or imaging findings consistent with inflammation. And so those cases are when we, try to be mindful of being, suspicious here as well.
It probably was a negative culture as well.
Yeah. These cases more typically, you've done sort of your routine evaluation. You've considered, a CNS infection, viral or bacterial meningitis, haven't come up with a specific pathogen, and are starting to entertain more of those unexplained immune-mediated encephalopathies. Certainly there are many, but once we start talking about those meningoencephalitides, one of the potential diagnostics consideration is a primary CNS HLH presentation.
Yeah, great, thank you. Yeah, no, we could go on for a long time talking about diagnosis, because it's obviously complicated. There are fuzzy borders around, what is or isn't HLH. But, one thing I just wanted to bring up is a bit of just raising awareness. About a registry. So we've developed a registry called Into HLH. And part of the goal of our registry is to really understand the full spectrum of HLH, to understand better about some of these maybe not so clear-cut defined cases, and also better understand what happens during therapy, because the data that are actually out there are really fairly limited in terms of outcomes, beyond simply survival. So I just wanted to raise awareness of that, and we're happy to collaborate with others if there's interest as well, in terms of other centers and academicians. So, well, thank you, Dr. Kernan, for this discussion. Hello, I'm Professor Michael Jordan. I'm an HLH specialist at Cincinnati Children's Hospital. I'm joined today by my colleague, Dr. Eric Gars, a pathologist at University of Florida Health, Gainesville. And in this module, we'll discuss the role of biomarkers and genetic testing in the treatment and management of HLH. So let's pick up on our patient case, and welcome Dr. Gars.
Thank you. So
in the last segment, we mentioned a case that was still fairly bland. Approximately 1-year-old infant male presented to the ICU with fever and rash with some persistence and splenomegaly. And the initial testing revealed a hemoglobin of 9, or 90 grams per deciliter in some countries, a white count that is relatively low at 1,400 total white count, and a platelet count of 60,000. So, and the inflammatory markers in this child were, perhaps not surprising for this discussion, quite elevated. So the ferritin was 13,000. So these are the quick ones that turn around, locally. So, what additional laboratory tests would you want to obtain at this point? So, Dr. Gars, can I turn that over to you?
Sure. So, generally it's the clinical team that are making these decisions about exactly what they would like to order. But in general, with respect to having HLH within the differential, a number of things to consider for rounding out the diagnosis would be to get a triglyceride level to get soluble IL-2 receptor. And then there's a number of other markers that could potentially be used that are kind of more recently described in establishing diagnosis, such as like a glycosylated ferritin. And particularly if you're considering a younger patient, genetic testing may be helpful for establishing that diagnosis, and getting that earlier rather than later may be helpful for making an appropriate diagnosis in a timely manner. But importantly, specifically if you're seeing biocytopenias and you're considering HLH, doing a bone marrow biopsy is particularly helpful in this context. Now, with respect to the criteria, none of those criteria have priority of one over the other necessarily, but finding HLH or haemophagocytosis within the bone marrow can be helpful for the clinical team to know that we're seeing a significant dysfunction within the marrow that might point to this diagnosis more strongly. Now, one thing that we know from looking at bone marrows from patients of all sorts is that haemophagocytosis is not specific to HLH. Most commonly, we see erythrophagocytosis in a lot of contexts, such as patients who have had chemotherapy, bone marrow transplants that are getting chronic transfusions and things of that sort. But the relevant question is in the context of a patient presenting with signs and symptoms of HLH, is haemophagocytosis something that is specific for that diagnosis versus something like sepsis? What we found is, in general, if a patient is presenting with true overt HLH, they're going to have morphologic findings of macrophage activation. And this has been described in models of HLH, genetic models of HLH, and we see it in patients where their macrophages tend to get kind of rounded up. Sometimes they have these cytoplasmic projections on them. Additionally to that, not just erythrophagocytosis, but we'll see white cells being engulfed by macrophages. And often we'll see multiple nucleated cells being engulfed by macrophages as well. And this finding can be somewhat subtle. And I think it's prudent, if you're considering from a clinical perspective that HLH is in the differential, to put it on the requisition form or let the pathologists know. Certainly, depending on the setting that they're in, they may have access to the chart, but that might not always be 100% available depending on the practice situation. So let them know, because the finding can be subtle. And I found that, and this is something you could potentially alert your pathologist to, that those cells might not necessarily be in the typical space that we would evaluate hematopoiesis in a bone marrow aspirate. In fact, maybe because of the density, they tend to be spread out along the slide, often at the kind of feathered edge, typically under the label at bone marrow aspirates from patients.
Yes, right, at the leading feathered edge, right? They get dragged out.
Exactly.
Yeah, Dr. Garza, as we noted, HLH is not a diagnosis that requires pathologic confirmation, though pathologic criteria are a part of the diagnostic criteria. There also are a number of clinical features that need to be manifest in order to come up with a clear diagnosis. But I'm wondering, in addition to having a classic, say, bone marrow biopsy, where else can pathologists be helpful? And I'm particularly thinking about, while we're still in the diagnostic odyssey, I'm not really sure whether the patient even has HLH.
Right. Thanks for that question. So there's a number of situations I think where pathologists can be helpful in assessing these patients. One is a patient, as you mentioned, where they're not exactly sure what is going on. The patient might be sick or might be kind of in the initial stages of manifesting all the features of HLH. We see that not infrequently in adult patients associated with malignancy. And the types of malignancy we see associated with HLH include the common ones like large B-cell lymphoma. We see it in myeloid diseases, MDS and AML. And then a number of rare lymphomas that can be difficult to diagnose pathologically and clinically. Things like extranodal NK T-cell lymphoma. And spanning children and adults, some of the other rare T-cell lymphomas that can occur in specialized populations that are immunosuppressed, or ones from different regions within the world. Things like systemic EBV positive T-cell lymphoma of childhood, hydrovacciniforme type lymphoproliferative disorder, and chronic active EBV infection. And so a pathologist might be involved. Maybe they're seeing the initial diagnosis of one of these diseases and could suggest the possibility of HLH in a patient that could potentially manifest it in the course of their disease. That happens not infrequently. Additionally, certain patients will present with infectious manifestations that might not be apparent clinically, things like fungal infections that might involve the bone marrow. I've seen a couple of cases of things like histoplasma and candidal infections that we identified because there were changes in the marrow, things like granulomas and such that we then stained for GMS and PAS to try to identify these fungi in these patients, then manifested clinical signs and symptoms of HLH. So I think that the pathologist can be involved in a number of ways in the diagnosis of these patients, and maintaining communication with the clinical team, I think, can be helpful, particularly if we're seeing something in the marrow. Because sometimes, I mean, I've seen a couple of cases in which HLH was not being suspected clinically, and I think it's becoming increasingly appreciated as within the differential of very sick patients, particularly in sepsis. We've caught HLH as in the assessment of these patients, first on the bone marrow, and alerted to the clinical team to that to round out the rest of the diagnosis.
Yeah, that's a good point. We should be asking you, not you asking us to think about HLH, right?
Well, most often what happens is the clinical team is most concerned. I think, though, that it's not 100%, and kind of maintaining a reciprocal relationship and considering that diagnosis and being in communication about it, I think, is prudent, particularly because of the time sensitivity of this diagnosis in establishing and initiating therapy. Let me ask you as well, Dr. Jordan, about assessing for genetic causes of HLH in adults that are presenting. I know there's an association with hypomorphic mutations in the genes associated with genetic HLH.
Mm-hmm. Yeah. So there are a number of case reports out there. I think that what's lacking is a really good series to demonstrate the true incidence of that. But I can tell you from experience that I've seen adults in consultation in my clinic. I'm a pediatrician, but I still have patients coming to me and up into their 70s, and most of them have either biallelic, sort of very mild mutations, or have single allele mutations that are ultimately kind of ambiguous, that would ordinarily we view them as carrier status, but they've had perhaps even recurrent sort of disease sort of manifestations that really do suggest that there's something unusual about this individual. I think there's a lot to learn. Probably, so young adults, I would say, certainly can have classic familial HLH, and we've seen a number of these patients, and they're described in the literature into the 20s and maybe even the early 30s. But when I'm referring to older adults, like 50s, 60s, 70s, that's where actually finding biallelic sort of, black and white familial HLH mutations is probably quite rare. Again, we don't really know the true incidence. And I suspect that we will, in coming years, find that many of these patients probably have clonal hematopoiesis, perhaps affecting the lymphoid compartment, that's leading to abnormal responsiveness to environmental triggers of various sorts. But that's pure speculation. All right. Hello, I'm Professor Michael Jordan, an HLH specialist at Cincinnati Children's Hospital. And I'm joined today by my colleagues, Dr. Kate Kernan, a pediatric intensivist at UPMC's Children's Hospital in Pittsburgh, and Professor Rob McLaren, a pharmacist at the University of Colorado in Denver, Colorado. Welcome, Dr. Kernan and Dr. McLaren. In this module, we'll discuss some treatment approaches for HLH and compare and contrast treatment for adults versus children with HLH. So let's start with a case from Professor McLaren. So I'll hand the discussion over to you at this point.
Appreciate it. Thank you, Dr. Jordan. This is a patient that we saw literally at the beginning of COVID. So there was a little bit of confusion going on at that time, obviously, but 74-year-old male who came to our emergency department, primarily complaining of abdominal pain, distension over the last week or two. progressively getting worse. He also had he was a pretty active patient, but had dyspnea on exertion. He was actually a skier, being in Colorado, hiker in the summer, that kind of thing, even though he had a past medical history of coronary disease with cabbage, hypothyroidism, and hyperlipidemia. He also had rheumatoid arthritis as a distant past medical history, nothing active right now. He eventually gets put on low-dose pressors, we presumably think because of septic shock. He's never intubated. However, he does develop anuric renal failure and some atrial fibrillation. And so you can see the labs there pretty quickly. He's got a little bit of a fever elevation, but really the remarkable thing was his extent of thrombocytopenia that probably sparked the discussion of HLH in this patient. Obviously on physical exam, splenomegaly, and on labs, hypertriglyceridemia, but this was sort of discussion on rounds. And so luckily within about, I think he came in early in the week, so within about 24 hours, we had him working up for HLH diagnosis.
Right. So we normally think of HLH in infants. It's increasingly recognized in adults. And this is a gentleman who's quite elderly and is meeting criteria, right? Is this sort of the typical diagnostic criteria for HLH. So what were the considerations for therapy in this individual?
That's a good question. I mean, initially, obviously, we're making sure this patient's getting the appropriate antibiotics to treat. He ends up with an empyema, interestingly, with an enterococcus empyema, so a little bit different. And that's what we thought was probably the influence of developing HLH. But certainly on rounds, we discussed everything from IVIG and anakinra. Eventually, we did settle out on the typical HLH 94 diagnostic criteria and the dosing there with etoposide. And he did not have any neuro dysfunction, so he didn't really require any methotrexate, but certainly high-dose steroids as well.
Now, he was an anuric renal failure, right? So I assume you guys adjusted his etoposide.
Yeah, so etoposide, even for an ICU pharmacist, isn't something we see very frequently. So as soon as I hear etoposide and they start mentioning these therapies, the first thing I do is call my oncology pharmacist and rope them in. And we have a lot of preset order sets we're an Epic system. So, we do have etoposide as a built-in order set, but not necessarily for HLH. So it requires a little bit of modification for us. But yeah, being an anuric renal failure, we ended up reducing the dose by about 50%. And as he progressively got better, the dose went up. He did move out of the ICU within about 8 days or so. So I didn't see the final result of it, but I'm sure he ended up on hopefully normal doses as his renal function got better. But, I think the other thing with this patient is they do come in with a hint of sepsis, septic shock. Giving the infusion itself is a concern in this patient. It did drop his blood pressure a little bit, something that you just have to slow the infusion down for him. But luckily we had the background oppressors there. Again, never high doses of oppressors, but just enough to sort of keep him, his MAP above 65. So I think in the ICU world in an adult, especially when they come in with an infection as their primary issue, you have to start worrying about some of the side effects of the drug therapy, but also eventual immunosuppression and downstream infections as well. So we obviously try to prevent PJP, put them on Bactrim, put them on some fluconazole to prevent some of the fungal infections, and eventually some acyclovir as well.
Mm-hmm. Yeah. And Dr. Kernan, thoughts about if this were a 1-year-old child instead of a 74-year-old male, about how you would treat a child whom you've diagnosed HLH?
Yeah, I think a 1-year-old child is interesting. I think I'll talk about two things. One will be a 1-year-old child and then a 16-year-old child, because I think that's sort of an interesting distinction to make. Given this scenario, with reasonable likelihood, I think we would have followed a relatively similar path in a 1-year-old child. You're saying a critically ill individual with, evidence of a specific infectious trigger, but with really profound signs of systemic inflammation, and certainly meeting diagnostic criteria for HLH. In the 1-year-old age group, in full disclosure, my shop in the presence of an identified infectious etiology is probably less likely to use HLH 94 off the get-go. We do use a lot of IVIG and anakinra regimens in Pittsburgh with good efficacy, particularly when we have like an identifiable known pathogen. And so that the working frame of reference is that this is a infectious driven pathology, and with source control of infection may see improvement without administration of chemotherapy regimens. However, we're also quick to if we don't see appropriate response in terms of the ferritin and readily available inflammatory markers, organ dysfunction, to transition to HLH94 if things are not improving. The 1-year-old, is right on the cusp of that age range that even we might consider just moving to HLH94. It's obviously definitive therapy for cases of primary HLH, and so in a 1-year-old, your suspicion should be higher. It's not a 3-month-old, so you're starting to get to that, of could this be a secondary phenomena for sure. What he was alluding to with the 16-year-old, I think, we don't see a ton of 74-year-olds. However, I've taken care of my share of 40-year-olds these days. In a 16-year-old, we would not administer HLH94 as our first intervention. I mean, this is somebody, in a teenager with this constellation of laboratory findings, we would be most typically pursuing sort of anakinra, IVIG, plus or minus some corticosteroid administration as well, and to monitor for response prior to reaching for agents like etoposide. I think that's variable. I think it's important to note that etoposide-based regimens have been shown to be efficacious in secondary HLH as well. So there's not, necessarily reasons to be hesitant if your inflammation isn't under control. But I also think, a lot of folks have seen good responses pursuing other immunomodulation strategies in the setting of infection-related HLH and MAS.
Mm-hmm. Yeah, I would agree. I'd say I think in most centers, including ours in pediatrics, then if there's a definite infectious etiology that's treatable, as opposed to, let's say, EBV, which is not necessarily, then we would drag our feet before onto much beyond steroids. Dr. McLaren didn't mention it, but I think I see in his case series or case description here is that this patient did have an unusual soluble CD25 or soluble IL-2 receptor alpha level of 32,000. So, quite elevated. Now, that I think was probably done in a lab that measured it in picograms per mil. And some labs measure in units and some in picograms, and the picograms tend to be 2 or 3 times higher, but still, even if it's 10 or 20,000, that's still quite elevated. And in a child, in a young infant, that would make me very concerned about HLH.
Yeah, for sure. Yep.
In a 74-year-old gentleman, that would make me very concerned about lymphoma, actually.
Yeah, me too. Yeah.
Yeah.
I think what's interesting and unfortunate or just worth noting about being suspicious quickly in your very critically ill patients is that, if you happen to work in a center where the turnaround on your SCD25 is going to be a little bit, obviously the sooner you get it out the door, the sooner it gets back. And it does have, in the range of things, perhaps more specificity than some of the other, lab markers we're talking about. But there's a time delay, and so that's a challenge when relying on it to make decisions. I don't know if you have other thoughts on that, Dr. Jordan.
It doesn't rule out the things that you're typically wanting to rule out for when you're thinking about HLH. But if you're trying to decide if this is garden variety sepsis or an empyema versus, some additional process with a lot of immune activation, then I think it's very helpful. So one last quick question for either of you guys or both of you guys. So, the risk of not treating, right, is the patient will continue to spiral and worsen, and you'll miss an opportunity to help them out. What about the risks of treatment, and in particular, one treatment versus another? As we talked about, steroids or etoposide or anakinra. Thoughts about that?
I mean, I think obviously immunosuppression is an issue when someone has an active infection. So from our standpoint, making sure there was decent antibiotic coverage for a few days before we started the etoposide was sort of important to us. So I guess maybe it was a good thing it took a little while to get everything organized to get things going. But probably didn't start therapy till about day 4 or 5. So it took a little while, but by that time the patient had we diagnosed empyema, drain was put, antibiotic therapy was appropriate, and they were looking like their fever curve was coming down a little bit. So maybe responding to antibiotics just from an infection standpoint. But so that was sort of our route.
I would just say that, to build on that, persistently elevated inflammatory markers, ferritin, CRP in particular, but cytopenias have been definitively shown to be of prognostic significance. Meaning, if your patient is not showing improvement in these, the likelihoods of bad outcome are high. And so even if you're on definitive antibiotic therapy for an identified pathogen, if the ferritin and CRP are not coming down, you're not out of risk. And so consideration for other strategies becomes important at that time.
Great. All right. Thank you. Hello, I'm Professor Michael Jordan. I'm an HLH specialist at Cincinnati Children's Hospital. I'm joined today by my colleagues, Dr. Kate Kernan, a pediatric intensivist at UPMC's Children's Hospital. In this module, we will discuss some considerations for the management of primary HLH. So let's pick back up with our initial case, that is of a 12-month-old male that presented with fever, rash, splenomegaly, was found to have pancytopenia, hypofibrinogenemia, elevated soluble CD25, elevated ferritin, and some mild hepatitis. And in fact, was found to have a mutation in SH2D1A, which is a gene encoding SAP, which is the protein associated with XLP1. So this is a child who presents with XLP1 associated HLH and no obvious infection associated with that, even though EBV is a major driver in that context, but not always. And so what do we consider in terms of therapy in this, what is obviously a primary HLH patient?
Well, I would say, this is sort of the ball's a little bit further down the road, in that we've sort of evaluated for infections, not found any actionable, at least at this time, and arrived at a definitive diagnosis of a primary HLH. And so these are the sorts of patients where we, in the ICU, would rely heavily on consultation from our heme oncology colleagues, and most typically would be expecting to start an HLH-94 regimen. And so, I think that's sort of where I would start, and that would be anticipating using etoposide in this patient, as well as some steroids.
Right. And so just to be clear, right, HLH-94, right, is etoposide given twice a week for the first 2 weeks, and then once a week thereafter, out to 8 weeks, along with dexamethasone, starting at around 10 milligrams per meter squared, which, if you think about it in terms of prednisone equivalents, is roughly 2 milligrams per kilogram per day, and then sort of stepwise decreasing from there. So the HLH-94 is pretty much the standard therapy that, or what we call standard of care in somebody that has definitely has HLH, or you have a really, really strong suspicion. It's not an ambiguous situation. In terms of treatment, now, Dr. Kernan, in the ICU, you probably treatment gets started, and then they head on to the oncology ward or the BFT ward, right? So in terms of what happens next.
Hopefully.
Yeah,
Yeah.
right. They don't linger.
Yeah, I certainly hope so. Yeah.
Yeah.
That, I think that what's interesting about cases like these is that, there's a lot of care that happens before that definitive diagnosis is established. And so what you do while you're waiting to, arrive at the definitive diagnosis. But hopefully you've achieved some stability at this point and get some disease control with the initiation of HLH94. At this point, I think discussions from my colleagues would likely begin about pursuing bone marrow transplantation for definitive cure. I mean, obviously that's out of the scope of my practice, but hopefully the patient is doing well enough and able to get disease control with HLH94, that is the sort of the goal for the majority of definitive cases with genetic findings.
Now, we could maybe back up one step, right? We talked about initially, the patient shows up and you're not sure what the diagnosis is, but you think it could be HLH. You're trying to rule out things that maybe wouldn't be best treated with HLH sorts of therapies. In terms of first-line therapy for patients, what do you consider at your institution sort of the variations or the options that you guys would generally consider?
Yeah, I think, I alluded to this a little bit in some of the other discussions. The younger the patient, the more likely we are to pursue an etoposide-based regimen, even in the absence of definitive diagnosis. Typically for us, that means less than 2, but the younger they are, the more likely. That just is an indicator of our increased suspicion for a genetic cause that we have yet to identify. In the, patients where things are somewhat atypical or they're getting towards or beyond that 2-year mark, we're more likely to consider variations of regimen that contain, in some cases, like a small degree of corticosteroid while you're waiting on culture results from in covering with antibiotics and waiting on viral testing. Certainly regimens with IVIG and anakinra. These are things that we often do to sort of, hopefully improve, but certainly sort of control inflammation as best we can. We're waiting on definitive diagnostics.
Right. So HLH94, that is sort of dexamethasone, and etoposide is an option. You mentioned things like IVIG, anakinra, maybe just monotherapy with steroids. Those are the sorts of things you consider where you're uncertain, perhaps, or sort of ramping up, you might say, to therapy.
Yeah, I think that's fair. And it has a little bit to do with how severe the inflammation is and how significant the organ dysfunction. And so the more severe and the more significant the organ dysfunction, the more likely we are to move quickly and completely into an HLH94 regimen. Although I will say in my institution, we're very quick to start patients like this on IVIG, steroids, and anakinra. So most of those patients have already been exposed and have not achieved adequate response by the time we're moving to HLH94, even prior to genetic diagnoses.
Yeah, I agree. At our institution, in the face of uncertainty, if somebody's not too sick, like crashing in front of you, then we'll start slowly. Typically, we'd start with some steroids. Like I said, anakinra, kind of plus minus. IVIG sometimes, especially if we think there's an infection that's really kind of driving or even mimicking sort of an HLH sort of process. Though those are, if somebody has familial HLH, then those are almost always inadequate, and you really need to move on to the etoposide, and there's a little point in delaying. And so now, in terms of these different options, so those are all the sort of the first line options. If those aren't working adequately, as you said, sort of stepwise, start kind of ramp your way up through steroids, perhaps at HLH94. What would you consider afterwards in second line therapies?
Yeah, I mean, second line therapies, I think, recently filling a space of a big question of what do you do now when nothing was working has really come to a really significant need is use of emapalumab. And so that most typically would be our next go-to agent. I think this is, very institution specific in that if the child had requirement for other kind of extracorporeal therapies while we were waiting for that drug, this patient would in all likelihood be on plasma exchange, but that's very institutional specific. And I think by the time you're getting to, insufficient disease control on those standard regimen, it does become a more problematic in terms of what's best to do next.
Mm-hmm. Yeah. In terms of use of emapalumab, I'll tell you, locally, we do not treat patients with emapalumab up front very often, if ever. We typically start with either steroids if somebody's seems to be quite mild, or we think there's some underlying trigger that we can treat readily. And we would then move on to steroids plus etoposide in most patients. But I will say we are fairly quick to add in emapalumab if we're not happy with the response. And it really turns out if you look critically at patients' response to etoposide in terms of their normalization of inflammatory markers, probably the majority of patients don't have what I'd consider a truly optimal response. So we end up using emapalumab quite frequently, but it is still definitely a second-line agent. And in fact, we have data. We haven't published these data, but we really think that we see evidence that it does facilitate ultimately the patient's progress to transplant and their success in transplant. In terms of the published experience with the international pivotal trial, there was about 2/3 of patients were able to survive and move on to bone marrow transplant, which we felt was a pretty good response considering that the majority of the patients on the trial were being treated in second line and had already failed one or more lines of therapy. And so while we don't ultimately know what the true denominator is there, in other words, we don't really know what to expect in patients that have to move on to second line therapy because that's never really been published in other contexts. Our clinical experience suggests that the outcomes are relatively poor. So addition of emapalumab does seem to be a very useful agent. And there are, clearly patients in whom they're not responding well to other drugs, but they do respond well to interferon blockade with that drug. And so I think that there's some variability in patients we don't fully understand, but in the end, we end up using it in really, I'd say almost the majority of our patients at some point or other. Well, I think that we are about out of time, and I think we've touched on most of, the issues we'd want to, but of course we could go on for another hour. Thank you.